Hi, I'm Phil Siegel, and I'm an endocrinologist at Toronto General Hospital and Mount Sinai Hospital. The focus of this video is to provide an overview of our current understanding of diabetes pathophysiology. I have received honoraria for educational work with the Canadian Council of Pharmaceutical Education, Medtronic, and Novo Nordisk. Illustrations from the CCPE do appear in this presentation. However, I was involved in the design and editing of these illustrations. So here are the objectives. By the end of this module, I hope that you'll be able to compare and contrast the pathophysiology of type 1 and type 2 diabetes and apply pathophysiology to the understanding of the differences in presentation, treatment, and complications between type 1 and type 2 diabetes. Diabetes mellitus is a metabolic disorder characterized by the presence of hyperglycemia due to defective insulin secretion, defective insulin action, or both. The chronic hyperglycemia of diabetes is associated with relatively specific long-term microvascular complications affecting the eyes, kidneys, and nerves, as well as an increased risk for cardiovascular disease. There are 2 points I want to highlight here. The first is that diabetes can result from defective insulin secretion and defective insulin action, or both. So diabetes does not simply equate to no insulin. The second is that diabetes is not all about high blood sugar, although this is very important, but about the long-term and serious complications that result from the chronic hyperglycemia. Broadly speaking, we can classify diabetes into 4 main categories. Type 1 diabetes results from autoimmune destruction to the beta cells in the pancreas, leading to insulin deficiency, and this can predispose to ketosis. Type 2 diabetes, which is by far the most common, comprising over 90% of cases in Ontario, results from insulin resistance at the level of the target tissues, as well as from insulin deficiency, and we'll discuss this more in later slides. Diabetes diagnosed during pregnancy is referred to gestational diabetes, and there are many other rare but interesting forms of diabetes, such as those that result from various genetic mutations or those associated with specific drugs. Now remember, the pancreas is both an exocrine and an endocrine organ. In type 1 diabetes, it is felt that there is ongoing autoimmune beta cell destruction in the islets of Langerhans, and this will eventually lead to insulin deficiency. Also remember that insulin promotes energy storage. With respect to carbohydrates, it increases glucose uptake by the cell. So without insulin, the cells can't take up glucose, and diabetes in the past has been referred to a state of starvation in the midst of plenty. Insulin also promotes glycogen synthesis and inhibits the liver from producing glucose through gluconeogenesis. Insulin promotes storage as fat in triglycerides, insulin promotes storage of fat as triglycerides in adipose cells, and also promotes the uptake and utilization of amino acids. So, when there's no insulin around, what would we predict would happen? Well, insulin cannot keep fatty acids inside the cells, and so they will leach out into the circulation as free fatty acids, which later form keto acids, leading to an acidosis. Cells won't be able to transport glucose into the cells, leading to hyperglycemia. And also the liver will be producing excess glucose through gluconeogenesis and breakdown of glycogen, which is called glycogenolysis. And this state, where there's no insulin, is often referred to as diabetic ketoacidosis, and it can be very serious. The processes that lead to a diagnosis of type 1 diabetes occur over many years prior to the diagnosis. There's felt to be some genetic susceptibility, which is triggered by an environmental factor. There's been a great deal of research into the various genetic mutations and polymorphisms associated with type 1 diabetes, as well as potential triggers such as viruses and other proteins such as those in cow's milk and infant cereals. But to date, no single gene or single environmental factor has been conclusively shown to cause type 1 diabetes. Regardless, these events lead to ongoing autoimmune beta cell injury and destruction, which is called insulinitis. But people have normal blood sugars and feel quite well during this time. It isn't until about 85% of the beta cells are lost that hyperglycemia occurs and patients present with a new diagnosis of type 1 diabetes and ketoacidosis. Following diagnosis, there's often a honeymoon phase where the pancreas is still able to secrete a small amount of insulin, but over time, this too fades and patients are left with a permanent insulin deficiency. The pathogenesis of type 2 diabetes is a little bit different. Insulin resistance at the target tissue is of primary importance. Insulin resistance refers to when a given concentration of insulin elicits a suboptimal response, such as lowering blood glucose. And it is one of the earliest abnormalities that detected in the majority of patients who are eventually diagnosed with type 2 diabetes. Now, the pancreas tries to compensate for insulin resistance by secreting more insulin, and this is called hyperinsulinemia. And for some time, it may be successful. But eventually, the beta cell will fail, leading to insulin deficiency. This slide further illustrates principles of insulin resistance. On the y-axis, we see insulin concentration in the serum, and the x-axis shows the time throughout the day. There are 3 peaks corresponding to increased insulin release from the pancreas with meals. The bottom line shows insulin concentrations in an insulin-sensitive individual, and the top in an insulin-resistant individual. Now, both of these individuals probably have the same blood glucose, but the insulin-resistant person needs to secrete, but the pancreas from the insulin-resistant person needs to secrete much higher levels of insulin in order to maintain that level of glucose. The most common cause of insulin in our Western society is obesity, particularly visceral adiposity. There are also physiologic reasons for insulin resistance, such as puberty, pregnancy, and aging. There are some genetic factors and rare genetic conditions that can lead to severe insulin resistance, and some medications can cause can increase insulin resistance and cause hyperglycemia, such as steroids or glucocorticoids, as well as medications used to treat HIV and other viruses, and atypical antipsychotic medications, which are used to treat mood disorders and schizophrenia. This slide illustrates some of the key concepts of the pathophysiology of type 2 diabetes. The diagnosis of diabetes at time 0 on the x-axis is preceded by years of insulin resistance. The pancreas responds to insulin resistance by secreting more insulin, up to 200% more, in order to maintain normal blood sugar. But eventually the beta cells start to fail, and while they are still producing excess insulin during this phase, they just can't produce enough, and diabetes ensues as a result of relative insulin deficiency, shown here between the 2 dotted lines. Those with relative insulin deficiency still have high serum insulin levels, which is called hyperinsulinemia, but it's still not high enough to compensate for the peripheral insulin resistance, and this deficit leads to hyperglycemia and type 2 diabetes. During this phase, many of our patients are treated with oral agents to control their blood sugars. But over time, beta cell function declines further as the disease progresses, and absolute insulin deficiency may result, shown here, where beta cell function falls below the 100% dotted line. At this point, many of our patients may require insulin injections. So I like to view diabetes as a spectrum. On the one hand are the types that are associated with insulin resistance, such as type 2 diabetes, and gestational diabetes is also felt to be towards this end of the spectrum. On the other end are those cases which result from pure absolute insulin deficiency, such as in classic type 1 diabetes from autoimmune destruction of the beta cells. You may find this table useful, which contrasts some of the differences between type 1 and type 2 diabetes. At the top, you see that type 1 diabetes is from insulin deficiency, whereas type 2 begins with insulin resistance and may in time progress to an insulin deficient state. 90% of cases are from type 2 diabetes, and type 2 diabetes is associated with obesity and metabolic syndrome, which you'll learn about in the module. Type 1 diabetes is associated with other autoimmune conditions, such as celiac disease, vitiligo, and autoimmune thyroid disease. Diabetic ketoacidosis can result from type 1 diabetes, but seldom from type 2 diabetes. People of Aboriginal and South Asian descent are at high risk of type 2 diabetes, while there seems to be a high prevalence of type 1 diabetes in Scandinavian populations. Often type 1 diabetes is diagnosed in young people and children, but not always. I do have some patients in my practice diagnosed who develop type 1 diabetes later in life. People with type 1 diabetes always require insulin injections from the time of diagnosis, whereas those with type 2 diabetes are often treated first with exercise, improved diet, oral agents, but may eventually require insulin. So I hope that you are by now able to compare and contrast the pathophysiology of type 1 and type 2 diabetes and apply these principles to the understanding of differences in presentation, treatment, and complications between type 1 and type 2 diabetes. I hope that you enjoy the module.